radiobiology, okay? This is just scratching the surface, guys. You'll get more into this with some of Sarah's classes, okay? So keep that in mind. If I repeat something, by the way, in my lectures, generally that means pay close attention to this, okay? All right, our first objective is to identify the source of ionizing radiation, list the units that we use to measure this, describe the source of radiation exposure, and explain the ways in which it interacts with matter, mainly our patients. List the permissible limits of exposure for us as occupational exposure and to the general public. Some of our other objectives are explain the reason varying sensitivity of human cells when interacting with ionizing radiation. We're going to describe the ways in which the entire body responds to this and discuss various practices used to protect the patient with excessive radiation. Discuss the various approaches used to protect an occupational worker, which is you in this case, from excess radiation, and describe several devices used to protect yourself and the patient. We deal in ionizing radiation. Why does this message keep popping up? Anybody know what ionizing means?
Destroys matter, or changes matter.
The loss of an electron to gain a net charge.
Right, it converts into an ion, right, through the process of losing an electron. Did everybody in the back hear that? You could, I honestly looked up what ionizing means. Just
It says
dictionary.
Textbook too.
Yeah. Because I start with the basics and I build from there. That's how I learn. Okay. In this particular topic, I highly recommend you guys do that as well, because this can get really crazy really fast and you're like, wait, how does that work? So a loss of electron results in the ionization of the atoms, and ionizing radiation is energy capable of penetrating matter and has enough energy to eject orbital electrons along its path. The benefits outweigh the risk as long as the radiographer minimizes the quantity of the radiation received. Okay, so it's the risk versus benefit factor here. And when we get into like mammography and like X-ray or breast cancer, things like that, you're giving radiation to a very sensitive part of the body, and how it the means meet the need. Does that make sense? So like you have to do it to check for a tumor, but this particular area of the body is super sensitive to the radiation, right? So you don't want to just keep exposing, but what you need to do is just that exam, okay? Sorry, I probably made that more confusing than I needed to. So some conditions necessary for X-ray production. These are the three main things that you need to remember. You have to have a source of the electrons. You have to have means for setting them at high speed. And then it has to stop rapidly. Stop that movement rapidly. And these three criteria are all met by the X-ray tube and the electrical system supply for the X-ray tube. There's two types of ionizing radiation that we're going to talk about. You have natural and man-made. Can anybody tell me a natural source? The sun, very good. And man-made is what we deal in, right? So background sources occur spontaneously in nature and are cosmic radiation from the sun. You have natural occurring radioactive substances in the earth. Anybody name me one of them? Uranium. Anybody have one of these detectors in their home? Radon? Medical and dental exams make up the largest portion of human-made radiation exposure. You have nuclear industry, nuclear medicine, radiopharmaceuticals, like isotopes they use in nuclear medicine. And then you have medical and dental. And those are all forms of man-made radiation. So, you've got the source of electrons, the high-speed motion, and the deceleration of the X-ray tube, right? Those are those three main things we're going to break down. This is all enclosed in a glass envelope, right? A vacuum, if you will. Anybody got their book open? I'm going to reference page 118 to the X-ray tube. It's on the next slide, but I think it's good to have a visual. So all these things are housed in the X-ray tube. You've got the cathode filament. When the milliamperage, the electrical current that's sent to it, is applied to the filament, it responds by boiling off electrons, known as a thermionic emission. I'm going to repeat that one more time. The filament in the cathode, when you have an electrical current or milliamperage, is applied to the filament, it responds by boiling off an electron, and this is known as a thermionic emission.
What page is it on?
118 is the picture. Figure 9.1. And you'll get these parts broken down in a much more detailed way in Sarah's class. Okay. When the kV or kilovoltage is applied to the tube terminals, the electrons accelerate toward the anode end of the tube. The X-rays are produced when they strike the anode and undergo a conversion that produces heat and X-rays. So two things get produced, heat and X-rays. Okay. The anode is on the target and the positive terminal of the tube. Any questions about that? And you'll start hearing terms MA or mass, MAS, and that's milliamperage per second. And then you'll hear the terms kVp a lot going forward. The X-ray tube design, which is that figure that I pointed out before, it's all contained in a glass envelope to create a vacuum. The X-ray beam is that's produced is heterogeneous, and heterogeneous in this means multi-energy, right? There's high energy, there's low energy, and the energy of the beam is expressed in keV. You're going to get a lot of units in this chapter, so try and keep them straight. So the energy beam that is expressed from the tube is in keV. Don't confuse it with kVp. Okay? The X-ray beam leaving the X-ray tube toward the patient is the primary beam. The primary beam is the X-ray beam leaving the tube towards the patient. Again, this is heterogeneous. There's multiple different energy levels within this beam. The X-ray beam can undergo three possible paths. Okay? They can be absorbed. They can interact with the matter, or in this case, the body, and transfer energy and scatter off. Or they could travel through the matter or the body with no interaction and no energy transfer. And it interacts 5 different ways. We're going to break down these 5 different ways, okay? But these are terms you're going to see over and over again, especially in your physics classes. You've got classic coherent scatter, photoelectric interaction, Compton scatter, you're going to hear that one a lot, pair production, and photodisintegration. Photoelectric interaction and Compton scatter are particularly important in diagnostic X-ray or radiography. So coherent scatter, both coherent scatter and the I'll just say PE interaction directly influence the patient and the occupational worker's exposure. And the X-rays transfer their energy to living tissue. That's what this means. The reason why techs take protective measures is because of coherent scattering. So this diagram is also in your book on page 119. So things you need to take away from this slide: coherent scatter is low energy X-ray. Okay? See that little squiggly line? It's not quite reaching that atom. Right? Not touching any electrons there. So incoming X-ray photon strikes the atom and is absorbed, which causes the atom to become excited. Atoms become excited and emits X-rays and cause energy built. But proceeding in a different direction. A change in direction when talking about X-ray production is called scattering. So change in direction is scattering. There's no energy transfer to patient or matter. The PE effect occurs when incoming X-ray photons strike the inner shell. See that in the first top image there, right? See the squiggly line? And it ejects an electron. This creates an ion pair. So the atom now becomes positively charged because it's lost an electron. The incoming X-ray photon is completely absorbed by the collision with the inner shell electron. This is responsible for the most patient exposure. This effect, right? PE effect. So when you're talking about PE, you're thinking patient, right? PE, patient. The electron leaves the atom, creating an ion pair. Free electron eventually unites with other matter, and secondary radiation is created as a result of electron cascade, right? So you've got to fill those holes in the atom. That's what the cascade is. Compton scatter is coherent scattering, coherent scattering, PE effect, and Compton scatter all occur within the diagnostic range of X-ray energies. The electron will travel until it combines with matter. But you can kind of see the difference in figure 9.4 and the one from 9.3. The incoming photon collides with the outer shell electrons and ejects it. And that scattered photon just continues on out, right? So that energy beam is changing direction. The incoming photon loses some of its energy through collision, scatters off in a random direction, and undergoes other interactions until its energy is totally absorbed. That vacancy in the electron is filled pretty quickly, and Compton scatter is what you should be worried about. occupational exposure. So it's bouncing off, say, a lead shield or a dense part of the patient, or out off the board that's behind the patient, the IR detector. Those things are what you're gonna get exposed with, right? So again, make that correlation, occupational exposure, Compton scatter. Some units of measure, it was developed in 1985 by, I'm not gonna say that big long word in French, but it's the SI units, okay? You guys are gonna need to know these front and back for the next 2 years. The Röntgen is measured in coulombs per kilogram. Radiation absorption dose is in gray. For most fluoro exams, when you guys get working in the hospitals and stuff, now because of Medicare and Medicaid billing reasons, we have to actually document when you're using live radiation on a patient, how many milligrays you've given that patient. And all of your equipment should be able to give you that at the end of an exam, okay? It's more information than you need, but just know that you will be using milligrays for documentation as you move forward in this field. Radiation equivalent to man is Sievert. And the Curie is in Becquerel. Yes?
So, are the milligrays for the radiation absorbed dose? Okay.
Yep. But for this, just know that it's gray. Milli is just, you know, part of the units. Nobody's getting kilograms.
But it's important to know for documentation on like in Medicaid and stuff.
Yeah, because you'll have to put it somewhere in your documentation when you do, say, a small valve follow through on a patient. Anything that's using live streaming X-ray for an exam, you'll have to document it. Or you'll see the tech document it if you're working with a tech when you get into clinicals. These units also pertain to us as occupational workers and what we receive. We'll get to that in a minute. Exposure, it measures the exposure in the air. It is not used to express absorbed dose to individuals. Not a measurement of absorbed exposure. The quantity of X radiation or gamma radiation that produces the quantity 2.08 to 10 to the 9th ion pairs per cubic centimeter of air. You're probably wondering, what the heck does that mean? It's talking about how much radiation has been put out into the air, right? Because from the X-ray tube to the body, you should have a gap of air, okay? Eventually being phased out as a unit of measurement, we don't use this as much. You will need to know air kerma, not necessarily for anything you do in the clinical field, but for your tests. And I did see this question in the RAD Bowl last year. It measures transfer of kinetic energy to tissue or air. It replaces that traditional unit of exposure X. It's the total kinetic energy released in a unit mass per kilogram of air. And it's measured in joules per kilogram.
I don't know how to respond.
Thanks, Siri. Didn't ask you. Air current is the total kinetic energy released in the unit mass per kilogram of air and is measured in joules per kilogram. So joules per kilogram air current. Okay, let's talk about radiation absorbed dose. It's in grays, so a gray is 100 times larger than the rad. So 1 gray equals 100 rad. And you will need to know some conversion at some point. Not my class, but but definitely in Ceres.
Equals
100 rad. One
R-
gray equals 100 rad.
RAD.
Alrighty? So this also depends on the type of tissue being absorbing the energy, right? Which do you think absorbs more? Soft tissue or bone?
Soft tissue.
Actually goes right through soft tissue.
Yeah, the bone.
Yeah, bone absorbs more. So, effective dose is expressed in sieverts, or SV. It's the unit of dose equivalent, which is the overall risk of exposure. This has to do with occupational exposure. So a sievert is 100 times larger than the rad. So 1 sievert equals 100 rem, R-E-M. And different types of radiation have different quality factors, or QF factors. Okay?
You said 100 REM.
R-E-M, like green. So you have alpha, beta, X-ray, and gamma. Everybody remember from physics, the little energy wave, the different levels. So they all have different quality factors. The quality factor for X-ray is 1. A radioactive measurement is a becquerel. It measures the activity of radioactive material, like I mentioned before, radiopharmaceuticals or radionucleotides. This is used in nuclear medicine and radiation therapy. Some standards of exposure. Because patients and workers are exposed to radiation or risk of biological effects, limits must be set to ensure safe practice for both the patient and the radiation worker. So, as an X-ray student, you are only allowed so much. At the bottom there on the screen, it'll tell you exactly how much you should receive per year. That's why we wear EMDs, which we'll get to in a minute. As an occupational worker, I am only allowed 40 REM in a lifetime. The whole body dose equivalent limit for the general population is 1/10 of the occupational worker's annual limit. So somebody that's gone through radiation treatments, do you think that they're high or low in that lifetime dose equivalent?
Super high.
Pretty high, right? But it's that risk versus benefit. We'll go back to that, right? They needed it to save their life. So this chart here, 9.1 on the slide, I would definitely start kind of looking over it and committing some of these SI units to memory. Dose response relationship. Anybody talked about ALARA yet to you guys?
No.
As low as
Reasonably achievable.
thank you.
So again, physicians use their risk versus benefit rationale when ordering ionizing radiation studies. I have x-rayed a pregnant person before because they had such bad swelling of their kidneys and they were unable to urinate. The patient was far enough along that the risk versus benefit outweighed actually harming the fetus because we were x-raying right through the abdomen where the fetus was to get a good idea of whether or not the kidneys were not drained. Okay? That's just a real life example of what a physician thinks about when they're ordering some things. Benefits of exam must outweigh the potential risk for radiation exposure. Doses should be kept as low as possible, and no dose is considered totally permissible. So no dose of x-ray is completely safe. Okay? So if you ever get a pregnant patient and say the ER doc has ordered a chest x-ray and you shield them and the patient starts asking questions about, well, is this safe for me? Is this safe for the baby? Starting out, I would tell you, go find a tech to explain it to the patient. But just know that there is no 100% safe dose of radiation, okay? This chart, you need to start looking at. This table is in your book, but know these three highlighted things along the side here. The annual whole body effective dose limit for us as personnel is 50 millisieverts. That's every year. You should not get more than that. You should get way less than that, technically, if you're using all the protective resources. And then maximum cumulative whole body dose limit is 10 millisieverts times your age. Whole body dose equivalent limit is 5 millisieverts. And there's that conversion, right, if you want to do the math, for the general population, which is represented by 1/10 the occupational workers limit. And this, you will see this again. I had a question on my boards back in 2010 about what is the whole body dose for a worker versus a patient. So you will see these numbers again. I guarantee it. Give you a little overview of the cell body, cell biology rather. Cells have two major parts. You have the nucleus and the cytoplasm. What's in the cytoplasm, guys?
A lot of stuff.
A lot of stuff. Huh?
Pretty much everything.
Pretty much everything. What's in the nucleus?
DNA.
DNA, right? The important stuff. Chromosomes, genes, DNA. If you had to guess, how much of the cell is water?
Like 80%.
80%. So there's two classes of human cells. You have the somatic cells and then you have the germ cells. Give me an example of a germ cell.
Reproductive is it reproductive tissue or reproductive cells?
Well, what's a germ cell? One specific. You have one that Dominic doesn't. I hear
ovums.
Ovums? Right? All right. So this should all just kind of be a review for you guys. It's on some level, just FYI. But somatics have 46 chromosomes, 23 pairs. Germ cells are reproductive cells, which is sperm and egg, right? And they have 23 chromosomes. When a cell absorbs that ionizing radiation we've been talking about, two theories of the cell irradiation damage exist. It's either a direct hit theory or an indirect hit theory. Cells have different degrees of radiosensitivity, right? Your bone has a different degree versus your ovaries or your thyroid or your breast tissue. All different parts of your body have different sensitivity. The indirect hit theory is key molecules are affected by the radiation depositing its energy elsewhere in the cell. Because the cells are made of 80% water, that indirect action occurs when the water molecules are ionized. The chemical change occurs and then enters the cell, which results in cell death. Okay? Again, this is the indirect hit theory, that there ends in cell death. The direct hit theory involves X-ray photons hitting an important macromolecule such as DNA, causing genetic like to do associations. So direct hit theory involves the DNA, right? See the D. So that causes genetic damage. I don't think either one is awesome. But what you're most worried about with, like, say, X-raying a fetus is that direct hit theory. Cellular radiosensitivity is principally a result of the rate and duration of cellular mitosis. I love these words. Law of Bergoni and Troubadour. Cellular response to that radiation, you can have a couple different things happen. You can have the cellular death, you can have delayed mitosis, and you can alter the meiotic rate. The cells try to repair themselves but depends on the radiosensitivity of the cell, the type of damage, the type of radiation that it received, right? Whether it's just X-rays or say like high-powered radiation from radiation therapy. How long that happened, your radiation exposure rate, and a total dose of radiation given. Fortunately, most cells can recover from radiation damage. Incomplete cell repair may have harmful effects. So an example of this would be you have a brain tumor and they're trying to shrink the brain tumor, and you're getting high doses of radiation directly to your skull and your brain to shrink that tumor. The radiosensitivity of the brain is pretty high, so it may not regenerate if some of those high energy beams are hitting good brain tissue versus the actual tumor itself, right? Total body response, an acute radiation syndrome. Anybody seen any documentaries on Chernobyl? Yeah. Anybody watch Oppenheimer?
Not yet.
Oh man, I highly recommend it. There's a lot going on in that movie. It's also very political, but
Just talking about that at work yesterday.
highly recommend those things. I highly recommend you watch Radium Girls as well, moving forward in this, because a lot of those things that we discovered from all of those incidences, dropping the atom bombs and the after effects on the people, Chernobyl, how the people that were first responders on the fire and things, what happened to them is what you're studying today. Okay? Like the acute radiation syndrome, the total body response at a particular dose is defined by the system most affected. Right? So these firefighters that went in and started hitting this fire in Chernobyl had a massive all-at-once dose of radiation, right, from that nuclear reactor. And it started basically melting them from the inside out. There's no better way of putting that. Acute radiation syndrome occurs when the organism is exposed fully, total body, to an external source of radiation given in a few minutes, which is exactly what those people were exposed to. There's different effects. There's early and late. Some of the early ones are prodromal stage, latent period, the manifest stage. And then it starts to affect, the late effects are somatic and genetic. And those people in, for Chernobyl, for example, that was radiation poisoning, okay? Some of the latent effects can be catatogenesis and carcinogenesis with cancer. They've even done studies on children that were close to Chernobyl and that those neighborhoods, that all those workers, they had their families living close by, and even some of the babies born after Chernobyl had a lot of genetic defects because that radioactivity just went out into the atmosphere.
Yeah, I was reading an article after watching Chernobyl that like 80% of the population population of Ukraine and surrounding areas are still affected and still have genetic mutations due to the
Yep.
radiation in there.
Because they were trying to put the fire out, but then they didn't realize that when you put water on it, then it's getting into the atmosphere, it's getting into the ground, it's getting into the water source. Like, it was just a bad deal.
Because, well, doesn't it, cause like, it has heat too, so like, it's like evaporating that water that they were putting
Yeah.
in the air basically, right?
And they had never encountered anything, so they didn't know how to fight this. And then on top of it, because where it happened and they were so secretive, they didn't tell other parts of the world until it was too late.
Even if in the movie it says total deaths, like 4. In the movie. And
Oh,
yeah, it's just like they're trying to keep it a secret like that.
Yeah.
Obviously no.
But Oppenheimer is a very heavy movie as well, but if you look at just the science of how they built the atomic bomb and then the effects afterwards, they kind of touch on that, like how the scientists didn't realize, I think, quite how catastrophic it was, and how far it would go. But what you need to take away from this slide is that there's early effects and then there's late effects. Some of those late effects can definitely affect genetics and the body, and generationally as well. Radiation syndromes, these doses are far greater than those received by what you'll receive in the hospital or by the patient. You'll get a patient, I guarantee you go, am I gonna glow after this chest x-ray? I don't know how many times in my life I've heard that. Most of the time I want to say, well, only if we're doing it in radiation therapy will you start glowing. But that's not even true either. That's just a bad joke. There's bone marrow syndrome, which occurs at 2 to 10 gray, which is the equivalent of 200 to 1,000 rad. Total body exposure, infection, there's hemorrhaging, and the patient becomes anemic. Gastrointestinal syndrome shows up between 10 and 50 gray. And again, there's that conversion of 1,000 to 5,000 rad. Most of the time, these patients have massive diarrhea, nausea, vomiting, and fever. Then there's central nervous system syndrome, and this dose happens above 50 gray, which is 5,000 rad. These patients can have convulsions, can go into a coma, and even death. A LARA, as low as reasonably achievable. So the cardinal rules for protection are time, distance, shielding. Time, distance, shielding. Commit that to memory, okay? So, this works for you as well as a worker. How much time you're in the room near the primary beam, right? How far back you stand from the primary beam, and whether or not you're wearing lead protection. Okay? There's a lot of new stuff out there about the need for shielding. You'll encounter this when you go into the hospital. When in doubt, still shield. Now, are you going to shield and put a lead apron on someone that you're doing hip x-rays on? You're going to put it over their pelvis? No, right? Because it's going to obscure what you need. But could you potentially put a thyroid shield on a patient? Could you potentially put a lap shield on a female patient to protect her chest or a pelvic? Yes, absolutely. Okay. Should you put a wraparound shield on a pregnant woman for a chest x-ray? Absolutely, right? Cover her abdomen. As long as that shield's not creeping up into her apices, her angles of her chest, it's protecting her. It's protecting that baby. But if you need to hold, like, say, a kiddo for a chest x-ray, you should be leaded neck all the way down. If you're female and there's a possibility that you're going to turn your back to the primary beam, wear a wraparound, okay? protects you front and back. Some internal ways that the X-ray beam is restricted is through filtration. Using the optimal exposure technique selection on most of these equipment will help you. So you're not giving a long exposure. And then the image receptor speed also has to do with decreasing the dose. So commit what ALARA means to memory and the cardinal rules for protection, right? Which are?
Time, distance, shielding.
One more time for me.
Time, distance, shielding.
Very good. All right, patient protection. The use of patient shielding is essential in the practice of ALARA. Shielding of a patient, their reproductive tissue, including the fetus, is no longer recommended. There's different schools of thought on that. As long as it's not in the primary beam, you're not hurting anything, okay? But you will come up against other people in the hospital telling you different things. So come ask questions. If you're working at Children's Mercy and somebody says, oh, we don't shield anymore, ask them why. Ask them to give you an explanation. If that still doesn't make sense, come back and ask me, Sarah, or Nicole, okay? There's primary versus secondary barriers. A patient shield type is a flat contact shield, a shadow shield. We use shadow shields on scoliosis. It's like this big thing that comes down while the patient is standing, and it helps with scatter. So it kind of clears up the image, right? Shaped or contour shields, which you can see in that picture right there, the kind of curved piece. That's more for our gentlemen patients. The flat ones is what you'll encounter a lot for little babies for gonad shielding. And then there's even lead strips that you can use to clear up a picture for like a lateral lumbar spine and things. I don't know how many facilities still use that. But you personally will use a lot of the wearable lead. So just going back, time is minimizing the amount of time around radiation. Distance is maximizing your distance from the radiation whenever it's practical to do so, right? So you've got a kiddo, you standing them up, you don't run away from the kiddo, you might have to stay in there, right? Those are reasonable things. If you're in a fluoro exam with the tech, you're still learning. The tech is handing the patient things, you're still here, take a few steps back, right? That's just adding to that distance to help you. Shielding using the lead aprons and gloves whenever necessary. Again, remember those cardinal rules. The distance is the best and most effective method of protecting you as a radiographer. For a pregnant student, it's very low risk to the fetus as long as you're using that ALARA. Dose limit for pregnancy term is 5 millisieverts. And this is one of those units that you need to remember. Declaration of pregnancy is voluntary. I'm sure you guys went over this before in your intro. It's in the handbook. A pregnancy announcement can be revoked, but the added benefit of declaring your pregnancy to myself, Sarah, or Nicole, is that you get a second dosimeter that you wear at your waistband to have an accurate reading of what your baby is possibly getting exposed to. My first child, I was not in radiology. My second child, I was 100% full on in radiology. I was doing fluoro exams, belly out to here, waddling around with 3 leads. I would wear 3 leads when I was in fluoro exams. But as long as I knew that my dosimeter badge for Mabel was very, very low, I was not worried about doing my job at all. Radiation monitoring. Any occupational worker who is regularly exposed to ionizing radiation must be monitored to determine estimated exposure. So you guys will all get dosimeters when you get to the clinical sites. There's different ones, they can look different, but they all do the same thing. I know Avila students wear these fancy ones, they look like a USB, like this almost, and they clip on, and it detects any kind of exposure, and then it has a port that when they turn it in, the instructor at Avila just plugs it in and sends off the information through a USB drive.
So if you've had like x-rays or CTs in the past, will those show up whenever you?
Nope, that has nothing to do with what you're actually occurring as an occupational worker.
Okay.
Now, does it go into your overall like history bank of what you've been exposed to? Absolutely. But there's no way of measuring that unless you can go back and say, I had an x-ray of the chest on this day and this day. Like some people can go back in their medical history and say, I've had a lot of x-rays, I've had a lot of CAT scans, depending on whatever pathology they might be suffering from, or radiation therapy. Like those patients have a better idea of what they've been exposed to, or they can find an idea of what they've been exposed to. Any worker who is likely to receive more than 1/10 of the recommended dose equivalent limit should be monitored. So you go up to the GI lab and you're doing a procedure up there with a C-arm. Those doctors should have their own dosimeter that they put on their lead apron, and they should be wearing during an exam. Okay? You guys see that? Tell somebody. They're not, if they don't have it. Because they should, because they need to know. They're getting exposed. They're not getting exposed all the time, say like our radiologists are, or like you are, but surgeons in the OR using a C-arm, they get exposed. The nurses, the circulating tech that's working in the surgical suite, they're all getting exposed. They all should have these badges, okay? This is known as a PMD, a personal monitoring device, or dosimeter, sorry. There are 3 popular monitoring technologies. There's a pocket dosimeter, there's an optically stimulated luminescent dosimeter, which is an OSL, and then the thermoluminescent dosimeter. There's also a film badge, which basically that film just gets exposed, and so it changes the actual film in it. This is an example of a dose report. Your person in the hospital that is chief radiation protection officer gets these from the company that you turn in your dosimeter to, and it's a printout. You can see what you're exposed to. At any point in time, you can ask. I believe Sarah also gets those, since she is technically that chief officer here for you guys. And this is a good table to kind of look at and understand a little bit. This is in millirems, okay? So a lot of people that are in high dose procedures like interventional radiology, where they're continuously fluoroing, they'll use lead protection in their eyes, glasses that have lead glasses. I know some surgical techs that wear these every day when they're in like long procedures like hip replacements, cardiovascular things, that there's continuous x-ray happening in the room. So this just kind of gives you an idea of the annual exposure that these individual parts should not exceed.
Are all dose reports in millirems?
I believe so.
Yes.
Yeah. I think so.
At the top says dose equivalent milligram per period shown.
Thank you. Thank you. I left my glasses upstairs. Okay, this is what a general dosimeter looks like. This is a brand Luxel OSL. Dosimeter is the most common method used to monitor personal exposure. Like I said, the ABLA students, theirs looks a little different. This is what you guys will get. And depending on what you work, when I worked full-time, I changed mine out every month. Now that I'm PRN, I will probably change mine out every 3 months. It's quarterly. So based on your work hours or your clinical hours.
Is it
I
something
think
that you send in, or like you give to somebody, they
So,
send it in?
there will be, so when you get yours from Sarah, and then she'll ask for them back. And I know that one of the rules kind of across the board, no matter what program, is if you lose it, if you don't bring it in when it's due, you won't be able to go to clinicals. If you lose it, report it right away, okay? So they can get you a new one. Because a lot of times you can't be in the clinical setting without it. It's one of those things they just kind of don't budge on, and it has to do with our certification. So make sure you keep this piece, and it comes on a little clip. I always put mine on my name badge, and then there's different ways to wear it when you're in a fluoro exam, or you should not be holding patients as students. But if you have to hold a patient, put it on your thyroid shield on the outside. But a lot of times those things get left on the shield itself. So just be very mindful of where this little piece of equipment is, okay? I would not recommend you leave them in your car. Remember, the sun is a form of radiation, so that can jack up your exposures. But you will get one of these, and you will have times where you have to turn them in, and I'm sure Sarah and Nicole will work all that out with you guys. That's a little ways away. But this is the most common one. There's other ones, but this is the one that's used the most. Though the OSL is most commonly used, it's convenient. It measures X-ray and gamma radiation exposure. It's typically worn for a 2-month interval. Like I said, that depends on how much you work and what your clinical hours are. If you guys are only in clinics 2 days a week, starting out, you may keep yours for longer, say, than the seniors who have an extra day. There's no immediate readout of the exposure, and it has a wide range of exposure sensitivity. So it should be worn at the collar level. At my hospital, you could not wear your badge down on your waist. You had to wear your badge up high. That's why I always wore my my PMD up on my badge. It was easy. It should be face forward. And like I said, if you're pregnant and you declare your pregnancy, that second one is worn at your waist level under a lead apron. You don't put it on the outside of your lead apron. So you want to know if there's any exposure through the lead apron when you're doing procedures. Monitor measures the quantity of the radiation received on the basis of the conditions in which the radiologic and imaging sciences professionals are placed. So, say you have a 2-week span in fluoro, okay? That a lot of times that's live continuous radiation for these exams that you're going to be in with the tech, right? You might have a higher readout those 2 weeks than say somebody else at your clinical site that's just doing main x-rays, okay? When you get into surgery, you're doing a couple of weeks of surgery rotation, you might be a little bit higher. Again, that's continuous fluoro, continuous radiation. And again, these are all collected by a specific date. I'm sure at some point Sarah will go over that with you, that she's your clinical coordinator. So, in conclusion, radiation has the potential to create ionization in human tissue. Ionization can be harmful and cause cell disturbances, and genetic alterations, right? It's high enough. Effects may be early or late, depending on the dose. What are those 3 cardinal rules for protection?
Shielding.
One more time?
Time, distance, shielding.
Okay, and then radiographers have a professional responsibility to consistently practice ALARA. I'm gonna come in next Monday, we're gonna do a little pop quiz, not for points, just to see how much retention we've got going on. I like to do this is something I've learned in 2 years, that you guys long-term will remember some of the things that I maybe said a couple times over in my PowerPoints by doing a refresher pop quiz the morning of the next week, okay? So, you might see a Laura on a pop quiz next week. You might see what the 3 cardinal rules are, the 5 different types of interaction, right? Compton, PE, all that. So, I will see some of you at 11. Yes, ma'am?
So on the